Thanks. I can't promise you that this will be more fun than interstitial lung disease, but anyway, here goes. So what I'd like to do today is not just run through a bunch of numbers and say this is obstructive, this is restrictive, but to give you a little bit of background about pulmonary function testing, looking at how we do the test, trying to apply some physiology to it so that it hopefully is a little bit more meaningful when you do look at the numbers, because it's never clear. Okay? All right, so the objectives are going to be to understand some of the physiological principles with respect to pulmonary function testing, some simple stuff, but key things I think we need to keep in mind. Look at some technical aspects, because you really have to understand the quality of the test. You know, garbage in, garbage out. It happens with PFTs all the time. And then just look at some specific cases of the typical things that we see in the clinic, and maybe look at some physiology, if you will, that you might see on the boards. Indications for pulmonary function testing, lots of them, as you can imagine, not only for diagnostic reasons, but they're used a lot for monitoring, and to me, that's the most important. You know, in interstitial lung diseases, the chronic slow diseases, and the trends are very important in helping prognosticate, so they're very useful there for monitoring. Very important for disability evaluations, people complaining about pulmonary problems and want to get money for it, they're critical for that. And then very useful in public health setting for large epidemiological studies and that kind of thing. I think the important thing to take away from this slide, though, is that by themselves, the lung function tests do not give a diagnosis. It's all contextual. It's the setting in which you see the pulmonary function test. They're helpful there, but they do not give a diagnosis. So I've divided this up into the three parts that we normally read on a PFT. We have the spirometry, which is kind of like the flow-dependent variables. I tell the patients, this is the power of your lungs. This is how we measure the power in your lungs. Part 2 is going to be about lung volumes, or the size of your lungs, is what I tell patients. Then finally, the gas transfer portion, which might be a little more difficult to wrap your head around, and hopefully we can clarify that, which tells us about how we get oxygen into our bloodstream. All right, so this is the typical spirogram that you remember from medical school, and here you are moving from your left to right. You've got a person breathing tidally, doing a simple spirometry. The technician asks the patient to take in a deep inspiration all the way to the top, and then they exhale forcefully all the way down to where they can exhale no more. And that's the forced vital capacity maneuver. It's forced because it's forced. It gives you the vital capacity. And that red line there is a spirogram. That's the maneuver that gives you a lot of different numbers that tell us something about airflow that we're going to be discussing. A little bit of physiology here. This is a Netter diagram. And the points I want to make here is that there are two things that limit the flow that goes through our airways. And number one is, of course, the caliber of our airways. But more important than that is the elastic recoil of the whole lung and the thorax itself. And you may remember this from medical school, this whole concept of the equal pressure point. So obviously to get air from the alveolus to our mouth, there's got to be a gradient from inside the lung to the outside. And in this example, it's an alveolar pressure of 30 centimeters of water. 10% is due to the elastic recoil of the lung. If I pop your chest right now, your lung will collapse to the size of your fist. And then there's this transpulmonary or transthoracic pressure of 20. So 20 plus 10 is 30, so that's the driving pressure. Now, as the air moves along the airway, what's going to happen is that when you reach a pressure inside the airway that's the same as the outside, you're going to get a choke point. So no matter how hard you push or bear down or what have you, airflow is going to always be limited by that segment. You can't make it come out any faster in the mouth. This is a dynamic thing. Think of it as a napkin ring that moves up and down as we breathe. That equal pressure point moves up and down. So this is really the way we limit our airflow. And so things that damage elastic recoil, and you'll see that in COPD, is going to have a lot of impact on how fast air flows, because our lung holds open the airways, that connective tissues hold open the airways. And when they get floppy, that equal pressure point slams down a lot earlier, if you will. You get that dynamic hyperinflation, air trapping, and loss of airflow. So remember the elastic recoil part of things when you think about pulmonary pathophysiology. This is a simple spirogram of a healthy resident from several years ago. On the left-hand side of the y-axis, you have volume as a function of time on the x-axis. And then you can see his spirogram took a deep breath in and blew out all the air until he could blow no more. And what we see here for this resident's height, age, gender, and race, there's a predicted forced vital capacity. This is done by getting thousands of people just like him and doing a bunch of tests. These are healthy individuals, and we come up with an average and a 95% confidence interval. So that's the average. So he's a little bit better than average, as you can see up there in the green line. All right. So this red line indicates the point at which the individual plateaus. In other words, they blow the air out until they can't blow anymore, and there's no more volume coming out. In a healthy individual, about 3 to 4 seconds. So you can imagine if you got someone with asthma or COPD, they may not get their air out, and I've seen people go for 20 seconds and still not empty their lungs. Okay, they're that airflow limited. So that's just to point out that we should reach a plateau very early on. Of course, here's the famous or infamous FEV1. His predicted was there at just under 5 liters. He did just a little bit above 5 liters. And the point I want to make here is that you get about 80% of all of your air out of your lungs, if you will, down to residual volume in that very first second. So it's age dependent, but in a healthy individual, probably people in your age group, you're looking around 78%. And then as we get to older people, it can go down into 65%. So it's going to vary with age. So the key variable here, though, is to look at the relationship between the two, because this is how we define if there's airflow obstruction. Right? This is the number. So his FEV1 over FVC is 0.83. That's 100% predicted for him. So his ratio is normal. He therefore does not have airflow limitation or airflow obstruction. Now, if we take that spirogram and we collapse it into the y-axis as a flow, right, time, volume change over time, dV over dt, and we plot that on the y-axis against the x-axis there, which is the volume, you can see our zero starts off to your right, and then the higher volumes go off to the left, and that's appropriate because total lung capacity is supposed to be right here. Now, the darker, straighter line is what the computer predicts this individual should do with their expiratory flow volume loop. So they take a deep breath in, they blow out, blow, 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 all the way till there's no more airflow, and then the technician says, suck it in deep, suck it in, suck it in. You know, when you walk by these pulmonary function labs, sometimes you do a double take with the language, you know. But in here the person is taking a deep forced inhalation in. So that completes the flow volume loop. So we have an expiratory portion and an inspiratory portion. All right. This line points to the peak expiratory flow rate, and this happens almost instantaneously. When we forcefully blow out, our fastest flow rates are within, 0.25 seconds or so. They're out. And this gentleman did about 12 liters. Each of these hatched lines is 1 second. So here's the FEV1 is over here. So the FEV1 is still fairly high flow rates. As we continue to exhale, obviously the flow drops until there's no more air to push out, and we go down to 0. The entire amount of air, this is the forced vital capacity. That red line I showed you at the beginning is right here, represented by this, and here are the flow characteristics for that expiratory maneuver there. All right. What's left, of course, after the vital capacity is this residual volume that we cannot measure with a spirometry, right? And we can only blow out so far that we've got air left in our lungs, and that has to be measured in a different way, which is part 2. Now, it's different for birds. Birds don't have a residual volume, and that's why magicians can put pigeons underneath their sleeves, because you can flatten out pigeons quite flat because they have no residual volume. All right. So if we take the residual volume and add it to the forced vital capacity, that gives us our total lung capacity. So when you look at a flow volume loop, you're starting here at total lung. Here's your forced expiratory maneuver, and then you've got this residual volume that's a mystery. Now, in this particular test, since we measured this resident's lung volumes, we know where the flow volume loop is supposed to sit. So our predicted volume loop here is exactly where it should be, and that's why, and he's almost right on top of that. He's a perfectly normal individual. All right. So let's take the example of COPD, where we have decreased elastic recoil. We lose that airway tethering I was talking about. The airways are more prone. Once you get that airflow going on the inside, it's like an airplane wing, and the pressure drops, that airway is going to tend to collapse. All right? So the more it collapses, the longer it takes the time to get the air out. So our time constants change. And not only do they get longer overall, but they vary by region of the lung, right? So in COPD, parts of the lung can empty out faster than the others. So it just depends on the heterogeneity of disease a lot of times, how air-trapped the patient is, may even reflect how they feel. All right. So this is an individual who has obstructive spirometry or airflow-limited spirometry, which is a better physiological term. This is a veteran. Again, we see a spirogram. You can see already that the configuration of this line is much, much different than the healthy individual. The predicted FVC is here, up to your right, and what this person actually did is here on the green line. Now, what you'll notice is that on people that have long time constants, a long time to get the air out, you don't see a plateau. In most tests, people are going to start coughing or they get tired and they stop. By American Thoracic Society criteria, you need to exhale at least 6 seconds to have a valid test. All right? But, if this gentleman could keep exhaling, and I've seen people exhale for almost 30 seconds if they have enough stamina, you carry this line out through the screen and out of this room, they may reach that predicted FVC if they're able to empty out all the air. But typically we don't see that. all right, because we don't have a plateau here. All right. Now the FEV1, though, look at the FEV1. What happens in 1 second? Very little of the air is out. The airways are immediately collapsible. That choke point immediately comes into play, and the amount of air that you push out in that very first second goes down in relative terms to the whole vital capacity, and that's why in these individuals we're going to get a low FEV1 to FVC ratio. This is only 36% predictive for this gentleman's age, height, race, and race. Okay. This is the parameter we look at when we tell you in our report whether this person is airflow obstructed or not. That's it. This is the one value that we look at. All right. FEV1, FVC can be in the normal range, out of the normal range. One can be normal. Typically, the FVC is going to be better in relative terms than the FEV1, and that's why we see the lower ratio. All right. Now, if we take that spirogram and do a change in volume over change in time and plot it on the y-axis here, again, we get our flow volume loop. We did lung volumes in this gentleman, so the computer knows to put this predicted expiratory loop here. It says that the total lung capacity should be about 7-ish or so. The residual volume should be from 0 to about 3 liters or so. Another thing, this gentleman is about 70-something, and as we get older, our residual volumes go up as well. So our lung capacities, our lung structure does change as we age. AA gradients widen, PO2s drop, things become older. So in this, one of the things you'll notice is that where the total lung capacity is in this gentleman, look how high it is. This person, because of loss of elastic recoil, loss of lung tissue, what's happened now? The chest wall has recoil and it wants to go this way. So you're losing recoil, inward recoil of the lung parenchyma, so now the chest wall wins, and anatomically the total lung capacity is higher. And this is called overdistension. All right, it's a critical term. We can't call that air trapping. We really shouldn't call it hyperinflation. Those are dynamic terms that go to more like residual volume, FRC, these things that go up when we're air trapping. All right, so this is an anatomical change because of loss of elastic recoil. You will not see this in an asthmatic, although you do see obstructive patterns in asthmatics. The loop is going to be inside or very close to the predicted loop because the elastic recoil of the lung is normal. So if you see someone with airway obstruction and with a normal lung volume, that still could be COPD, but that's what you're always going to see in a true asthmatic. You only see overdistension in COPD. Okay, important distinction. Here we have the forced vital capacity from here to here. This is the total maneuver here. This is the inspiratory loop coming back. RV is huge in this individual. All right, the airways are very floppy. When he does a forced maneuver, they just slam down at a very high volume, giving this very increased residual volume. This is obviously a very extreme case of severe airflow limitation. And the total lung capacity, as I pointed out, is huge. Okay, let's take the opposite. We've looked at obstructive patterns. Let's take a look at a restrictive pattern. In this case, I pick my favorite class of diseases, the interstitial lung diseases. And here, you can think of it as the opposite. You've got increased elastic recoil with more tethering of the airways. And in fact, in early to mid ILDs, you've still got well-preserved lung volumes and so much traction on the airways that the airflow can actually be higher than normal. And I'll make that point more clear when we look at the flow volume loop. So you can actually have hypernormal airflows in interstitial lung disease. Okay, not neuromuscular. You can be restricted from scoliosis or some kind of neuromuscular deficit, but the elastic recoil of the lungs is normal, so you will not have increased airflow in a neuromuscular impairment that causes restriction, only in parenchymal. All right. So here's an individual who just happened to have sarcoidosis, and she has this spirogram here. As you can see, the configuration is the same as a normal. It's a baby normal, basically, when you look at these restrictive graphics. So here's the volume, and here's time down here. And we can see here the predicted FVC is here. The FVC is clearly down. But unlike the other case in obstructive lung disease, we have a nice plateau here. That's what I think I try to demonstrate with this roving red line, is that the plateau, there's a nice long plateau. And in fact, on pulmonary function testing, you really want to look for a 2-second plateau as part of one of the quality measures of the test, is the reproducibility measure of the test. All right. The predicted FEV1 is up here, and she was down here. There it is. Look at the ratio, though. It's going to become very obvious that it's essentially a fairly normal ratio. Look at this. The FEV1-FVC ratio is normal. So this is a person with a restrictive lung disease. She has sarcoidosis, but the relationship between FEV1 and FVC is preserved. So we can say here there is no airflow limitation. I mean, that's how I start my dictation. Spirometry shows no airflow limitation. All right. Do the same thing as we did for the other two. Collapse down the spirogram into the y-axis. Here's a flow axis, and here's the volume axis. And the line here is predicting where she should be. And you can see that her loop is shifted to the right, opposite of the person with obstructive lung disease. Okay. A couple of other things that you'll notice is that for this lung volume, so let's say here at about 3.5 liters, the predicted flow rate should be about right here. You can just carry that at between 3 and 4 liters. I don't know if the huge population there at the VA can see this, but between 3 and 4 liters, here's the flow rate. Look what she did at between 3 and 4 liters. Flow rate is way up here. So for the same lung volume, her flow rates are much higher than predicted. Very classical for a parenchymal lung disease, a diffuse parenchymal lung disease that increases elastic recoil of the lung. If this lady had, myasthenia gravis or something like that, this loop would be a baby loop, and it would be pretty much inside of the predicted loop because the flow characteristics would be unchanged for that same lung volume. Very, very clear and interesting distinction that sometimes we can use when we read the PFT, say this person's restricted, flows are higher than expected for given volume, suspect a parenchymal process. That would be a reading on one like this. FVC, again, is between here, total lung capacity. And look at the predicted. It's much lower than the predicted total lung capacity for this individual. RV is here, which is smaller than the predicted RV, which should be somewhere closer to 3 liters here. And again, the total lung capacity. All right. So let me walk through a couple of more unique flow volume features, because you probably will see these on the boards. They're a favorite, and they're easy to put on there, easy money. So what I'm showing you here on the left side of this, on your left side of the slide, is this schematic of my terrible drawing. The red lines indicate the level of the clavicle. So anything below that is intrathoracic, and everything outside of that is extrathoracic. And here we have the extrathoracic trachea, and we have an intrathoracic part of the trachea going into the left here and into the right. So we're going to talk first about the variable extrathoracic obstruction, which is a classic board question. It's always somebody with a big goiter or someone who might have some vocal cord dysfunction, something that's going to have something to do with some abnormality in the extrathoracic airway. And here's how it works. All right, when we exhale, obviously the pressure inside the trachea has to be greater than in the air, otherwise the air would not, or what we exhale would not come out into the room. So if we have a variable obstruction here, like a goiter that's going to can expand in and out, the tendency is going to be to push out. So your expiratory loop is going to be fairly normal, okay, as we see here. I'm playing with a healthy resonance drawing here. When we inhale, the opposite happens. The pressure inside the extrathoracic trachea is lower than the ambient air, so it's going to be pushing in. So if you've got a goiter sitting here now, everything kind of tends to collapse in, and you'll get truncation, what we call truncation of the inspiratory loop. All right, you go breathe in like that. Airflow immediately drops, and you just cut off the airflow down here. All right, so this is a classic variable extrathoracic obstructive pattern. Okay, let's take a look at the fixed airways pattern. This might come around too, and basically what you're looking at here is any fixed obstruction. It can be extrathoracic, but most of the time it's intrathoracic. We see it a lot in people who've been intubated for a long time. They get a tracheal stenosis, right? Endobronchial tumors, which is exemplified here. Or fixed vocal cords for whatever reason that they don't move. I mean, that would be an example of an extrathoracic fixed obstruction. But what we see here is really a truncation of both, and I'm going to demonstrate that here. When you exhale, you've got a fixed obstruction. Airflow drops beyond the obstruction. That's your choke point right there. So you're going to truncate the top part of your flow volume loop. So you cut it off. Likewise, when you inhale, same deal. Air is coming in. You've got your fixed choke point here. The airflow is going to be limited coming in. So when you inhale, you're going to truncate the bottom. So a square-looking flow volume loop is a fixed obstructive pattern. All right, and the classic question involves someone who's had some kind of trauma or been intubated a long time, that kind of thing, or has an endobronchial tumor. They might show you a chest X-ray with a tumor there as well to beef up the story. Okay, so remember obstructive pattern, normal pattern, restrictive pattern, variable, and then fixed obstruction, and you should be able to get all the questions on the boards that you'll see on the medicine boards. I saw those kinds of questions on my medicine boards. I barely remember it, but I remember seeing those. Talk a little bit about post-bronchodilator PFTs. If you look at the asthma national guidelines and the gold criteria and so on, everyone talks about doing pre- and post-bronchodilator. And perhaps it's a good idea that when you first do a pulmonary function test in your patient, especially if you're suspecting an airflow problem like asthma or COPD, it might be a good idea to get pre and post bronchodilator, although it really has no bearing on how you treat the patient. If they're wheezing, they're symptomatic, you're going to treat them. And whether or not they respond on this test has no bearing whatsoever on how you treat the patients. People have looked at, does a positive test dictate a specific regimen? No, it does not. Also, this test has a 20% false negative rate, meaning that someone who might otherwise respond to bronchodilator is not going to respond on that particular day in that particular setting. All right? So we can't use a negative test in someone who's symptomatic to deny them therapy. So that's the worst thing that you could do with a bronchodilator test. Nevertheless, demonstrating bronchial hyperresponsiveness does give you a little bit more information about pathogenesis, so it's recommended. I may do it once. I rarely do it. I don't really believe in it for clinical purposes. It's very important for disability. So what is a positive response? In this particular example, this individual has an FEV1. You can see the ratio, first of all, is quite low. It's 42, predicted as 79. So the FEV1 is 1.91 liters, 56% are predicted. They're able to exhale long enough to get a nice FVC out. It's at 103% predicted, so therefore your low ratio. We give them 2 puffs of albuterol as typical in this country. You wait 20 minutes, and then you repeat the spirometry. That's the standard post-bronchodilator test. This individual has a tremendous jump up in the FEV1, as you can see here, going from 1.91 liters to 2.54. In a human adult, increasing by 200 cc's, it's sufficient to call it a positive test. You don't really necessarily have to remember a % change, okay? Because if I repeat the test in you over and over and over again, the intra-test variability rarely is, maybe 195 cc's. It's very unusual to get more than 200 cc's one way or the other in a healthy individual repeating the test over and over and over again. So if you go over 200 cc's one way or the other, it's probably a significant change. So this person indeed has a significant change. All right. If anyone has any questions in between, please feel free to interrupt. All right. And so this was a 33% change. It depends on who you read or where you want to set your thresholds. 12% change, some people consider significant. Some people consider 15% change significant. I think we hear 12% a lot. Just one slide on bronchoprovocation, a test of bronchial hyperresponsiveness, not hyperreactivity. The true word is hyperresponsiveness. It means you're more twitchy. It doesn't mean that your airways are any stronger or faster than anybody else, which is what reactivity refers to physiologically. So we look for responsiveness in airway pathophysiology. Typically, we do it with methacholine, but we can use histamine. If the person is already obviously airflow limited and the FEV1 is low, you probably don't want to do the test because it could be dangerous to do that. So you want the FEV1 to be greater than 70% predicted. And then we basically give some, there's little ampules of methacholine that's serially diluted. And you start obviously with the lowest dilution, like 0.025 milligrams. Give them that. It takes about 3 hours to do this test. It's not a quick test. And then you wait about 10 minutes. You do your first study. Then you give them the next dose and give them the next study. And you measure the FEV1 until it drops by 20%. Now, all of us, if we get enough methacholine, are going to drop by 20% eventually. So obviously there's a dose issue here. A very positive test is less than 1 milligram, would be moderate to severe bronchial hyperresponsiveness. 1 to 4 milligrams to cause a 20% drop would be mild. 4 to 26 is borderline. Most of us probably, if we're healthy and don't have asthma, or somewhere between 16 or so and above is where we're going to hit the 20 mark. So once people get up to around 16 or so, the test really doesn't tell us much about bronchial hyperresponsiveness. It gets lost in all the noise. Okay? So a positive test indicates that there's bronchial hyperresponsiveness regardless of what might be inciting it. It doesn't tell us what's going on. All right? And then when we're done with the test, we give a couple of puffs of albuterol typically. Okay? Some fancy, sophisticated labs can actually take workplace materials. They ask the patient to bring them in. They put them in a closet and let them work with the material and measure the FEV1 before and at times after they've been working with the material. All right. Okay, so now moving on to part 2. I think it'll be a little bit quicker. We're going back to our spirogram here. You're sitting in a chair right now, sitting here breathing at tidal volume. Take a deep breath in, blow it all the way out. That gets you to vital capacity, but obviously it misses the residual volume as we've been talking about. So to get the different compartments of the lung, which I'll go through here momentarily, we want to know what the total lung capacity is. And we have 3 different techniques really that will get us there. I'm going to briefly describe each of these to you. All right, we want to get the total lung capacity. We can do it by helium dilution. I have a picture of that. We can do it by nitrogen washout. These are the dilution techniques. Or we can do it by body plethysmography, which actually gives us the FRC. But since we can measure the ERV here, you know, at the bottom of tidal breathing to the top of residual volume, we just subtract that out from the FRC and we can get our residual volume. This is by far the most common test. It's a lot quicker. Ironically, it is the hardest one for the patients to perform, but we can do this very rapidly, whereas these require some equilibration time. All right. There's the expiratory reserve volume. So if we can calculate the FRC, we can measure this by the spirometry portion of the lung volume measurements. We always do a spirogram when we do the lung volumes, and that's what gives us our other volumes here, inspiratory capacity and so on. A little bit again about elasticity in the lung volumes. If anything, when you get out of here today, you'll be thinking more about the elastic components of the lung as it relates to pathophysiology and how lung function testing works. So here's a person who's breathed all the way out to residual volume, and what you have is this tug of war, these opposing forces between the thoracic cage and the going outward and the recoil of the lungs wanting to go inward. So obviously when we've pushed all of our air out and our thoracic cavity is the smallest, the recoil forces are going to want to re-expand it. Those are going to be the strongest forces. At functional residual capacity, the forces are perfectly balanced. And when you think about lung function testing, and you want a starting point somewhere, because we breathe cyclically, start at the FRC. No flow, all the forces are balanced. That's kind of your starting point. It's a good starting point when you want to think about lung pathophysiology. Think of the FRC as the golden point. At a larger lung volume, of course, the lungs are expanding, and now the tendency for them to recoil inward grows, and the tendency for the chest wall to expand outward decreases. So we're putting energy into the system. This is a no energy situation here. Both of these require metabolism and energy. Okay. And then at approximately 70% of total lung capacity, the recoil of the thoracic wall is gone. And this is important mainly when you think about exercise. When you're out there huffing and puffing, you're never going to inhale the total lung capacity. Just the amount of work to get you that little bit of extra volume is just not worth it. The metabolic expenditure is just not worth it. It's not very efficient. So when you're out there running a marathon or what have you, you're probably never going to exceed 70% of your total lung capacity when you inhale, somewhere between 60 and 70%. All right. And then, of course, the total lung capacity, all of these components are wanting to push in. Very, very inefficient energetically. But there it is. All right, so this is the first technique that one can use. I've actually never seen it used. I've only read it out of textbooks. But it's very simple and very straightforward with the helium dilution. You have your system here. You have a Bell spirometer here. You've got your circuit. And you know how much, you know the density of the helium here, the concentration. Valve is closed. You open the valve and just ask the patient to breathe in and out. Nose is pinched, of course, right? So the helium now is equilibrating between the system here and the lungs. You're constantly pushing in oxygen because we consume oxygen and scrubbing out carbon dioxide so you can keep the volumes equilibrated. And then you measure the density of the helium at the end, and the less dense it is at the end, the bigger your lungs are because it's diluted into more space. This is just a diagram here, starting out helium percentage here, and then the person's breathing, and it equilibrates down here. And then you can calculate the total lung capacity as you saw in that picture. All right. I'm not aware of any labs in any system I've been that use this. Nitrogen washout involves the patient sitting in a chair, nose pinched, they're breathing 100% oxygen. And we're basically measuring here with a spectrometer, breath by breath, the percent of nitrogen. Right? So with each breath, since we're not inhaling any nitrogen, we're washing out what nitrogen we have in our lungs, and we start out at 78%, which is what we're breathing right now. All right, so with each breath, it drops. And after a few minutes, you get down to less than 3% nitrogen, and you can use that area under the curve to calculate the lung volume. This is a test that we use fairly commonly when a person cannot do plethysmography, or when we want to do some manipulations, which I'll show you in a minute. We sometimes do both, nitrogen washout and plethysmography. So that's the second way we determine lung volumes. Third way, and most common, is the plethysmographic technique, and it works on Boyle's law, and it works only because gas is compressible. If gas were not compressible, we could not do this. All right. The simplistic way to explain this, but the one that makes intuitive sense, is here you are in a box that's totally sealed. You're breathing through a circuit here. All right. And then the patient is asked to put the hands on the cheeks, and then the technician will push down a valve, a flexible valve into the circuit, which essentially blocks the circuit, and the patient is asked to pant. They pant at about one breath per second, like this. And what this does is it generates a pressure across this, and it makes it go back and forth, and you measure the slope of the pressure with this, with a device here. At the same time, you're measuring the pressure inside the box, and then you know the size of the box. The X value is what's the size of the lungs, right? All right, and then you do the, the mathematical manipulation. So basically, your functional residual capacity, and I failed to mention, I'm sorry, we start the test with the patient at the end of a tidal breath. So what you have in the lungs is just FRC. So the technician watches the spirogram, and when the patient hits the bottom part of the tidal volume, boom, they put that valve down. So the patient's panting from FRC. So the value that we get down here is the FRC, which is atmospheric pressure times the change in the body plethysmographic pressure over the change in at the mouth, pressure at the mouth. Okay, that's how we can calculate it. Very, very, very nice and clean. Technically, you have to be careful for various reasons. There are certain systematic issues, and also patient performance is important. That's the only drawbacks of this test, but otherwise very clean. This is just the slope of the, here's the body box pressure, mouth pressure, and you can use the slope to calculate the FRC. So this is a case history. This really happened. This is a veteran, really nice guy, a big-time smoker, was on oxygen, could barely walk, and he had this big bullet here that you can see that I haven't yellowed out. And so we wanted to determine whether bulectomy might or might not help this individual. So we did lung volume testing to see how much air was in that bolus, how much we would be removing. And we did this by nitrogen washout. And think about it. It makes sense, right? There's nothing to wash out here. There's no air movement in here at all. So all we're measuring is the air that's washed out of the gas of the places that have conducting airways going through them, right? In contrast, plethysmography, because of gas compression, it has nothing to do with air movement out of one compartment to the other, measures all of the lung volume, right? So now we can take the lung volume measured by nitrogen washout or helium, subtract it from plethysmography, and get the size of the bullets. We did that. It was huge. We took it out. Patient was great. Got off of oxygen, was able to climb upstairs again. He felt so good he decided to start smoking again, and a year later was back on oxygen. Okay. So here he is pre-bulectomy. There are other things that we look at, just FYI. There's a lot of crowding down here. We look at we do VQ scans to see, how much perfusion is going to which side. So there are various manipulations we do before we decide to cut out a bolus. But it did a nice job in him. It did real nice. Unfortunately, he started smoking soon after that. I don't need to do that one. Okay. So right now, let's just go through a few. What am I going to do with this? I apologize. Looks like this slide came out of place. Where did I do that? Oh, well. Okay. I'm just going to flash through these because I think I've already made some points about the flow characteristics, which is really what we're looking for, the flow volume loops. And just to reiterate that in an obstruction with destruction of the lung and a loss of elastic recoil, you get over-distended. Remember that term? Airflow limited, over-distended, huge residual volumes. Total lung capacity is huge. And here's our restricted one. Probably the new thing today, for the given lung volume in people with parenchymal lung disease, the flow is much higher than it would be predicted. So that tells you that they're restricted, but it's a parenchymal process with increased elastic recoil of the lung. Okay. All right. So we'll finish off by talking a little bit about gas transfer, or the DLCO. The DLCO is a misnomer. It's not a capacity. It's not a diffusion. It's a measure of bulk gas transfer, how it gets from one compartment to the other through some type of resistance, like the alveolar capillary membrane. This is an electron micrograph of just that. Here's the alveolar side off to your left, where we have alveolar oxygen. And this just to demonstrate what that molecule has to traverse to get to the hemoglobin, which is where we want it, so it can distribute it to the body. So we have two cell membranes, or two cells, and then one shared basement membrane. There's a little bit of plasma. Then there's the RBC membrane before it gets to the hemoglobin. So that's the physical part, or resistance, if you will, to diffusion. And then we have this thing called theta VC, which is really the vascular volume, the corpuscular volume. How much blood do we have in the lung at any given time? Right now, sitting in the chair at rest, you probably have anywhere from 250 to 300 cc's of blood that's seeing gas exchange surface in your lungs. If I take your lungs and spread them out, they'll cover more than twice this stage. The surface area is huge. And of course, the capillaries are maybe 8 microns thick, so the red blood cells are lined up one next to the other because you want to reduce that space for the molecule to get to the hemoglobin. So the lung is very interestingly designed. So the entire diffusion of the lung depends on the diffusibility of the membrane, which is really in human pathophysiology just a minor component. Even in interstitial lung disease, where you get damage here in the interstitium, that is not so much an impediment to transferring gas from the air into the bloodstream as is destruction of perfusion units and getting more blood into the lung to receive those molecules. So by and large, it's really this component here, this theta VC, that's important in determining how fast gas is going to transfer from the alveolar side to the blood side. These are just the units you'll typically see. How many mLs of carbon monoxide can we push across per millimeter of driving pressure per minute? That's just the unit. When you see the number, those are the units for that. Okay. This is just showing a capillary bed spread out. This is a frog, Kermit. All right. So now let's get into how we measure the DLCO. And I think if you understand how we do this with the patient sitting there, it makes a lot more sense when you look at the numbers. So in this test, the patient again is in a chair, nose is pinched, they're breathing in and out of a circuit. And they're breathing in and out. They blow all of their air out down to residual volume slowly. It's not a forced maneuver. And then the technician will say, take a deep breath in, and they hit a button. And when they hit the button, the patient takes a deep breath in, then they hold their breath for 10 seconds. And that's where the technician, you walk by the door saying, hold it, 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 hold it. And the patient's there turning red and, sweating. Sweat is dribbling down their face. They're doing a DLCO maneuver when you see that. Now, when the technician pushed the button down, it gave the patient this gas mixture here, 0.3% of methane and 0.3% of carbon monoxide. Okay? All right. Now, the carbon monoxide, obviously, if you remember from medical school, is very easily transferable, very soluble, goes right through and has a tremendous affinity for hemoglobin, much more so than for oxygen, right? So then you may ask, why do we use carbon monoxide? Why don't we just use oxygen? That's what we're trying to measure. Well, the thing is that the driving pressure, the gradient for oxygen is so tiny, the equipment to do this and the conditions need to be so precise and sophisticated that it's impossible to do in the clinical setting. Carbon monoxide is much easier to measure. Driving pressure is much greater, a little bit more room for error and still get good information. So that's why we do this. So we take 1,000 people just like you, and we do 1,000 tests, and we say, well, this is how fast it should go on average, and we have our confidence intervals, and that's how we get our predicteds for carbon monoxide. All right. Now, when the person exhales at the end of those 10 seconds, the red line represents carbon monoxide. Okay. And then you would say, well, wait a minute. It went into 0.3%, and it came out at 0.1%. What happened to that extra 0.2%? Well, as we just discussed, it transferred across. It met the hemoglobin. It flew through the lungs. It went to the rest of the body, and there's a constant new RBCs there coming along to pick up this carbon monoxide. So the reason the carbon monoxide is lower is because it's been transferred and carried away. Methane. Now, why do we use the methane? Well, the methane is very different molecularly from, or behaviorally, if you will, from carbon monoxide. It's an inert material. Okay, it's easy, like carbon monoxide, very easy to measure with an infrared spectrometer, which is what's inside your DLCO machine. So in real time, we can measure. They have very specific peaks. So it's very easy to measure concentrations of these two gases. So it does not cross the alveolar capillary membrane. What it's doing during that 10-second breath hold is it's distributing throughout the aerated parts of the lungs. And that's where we get that VA, that alveolar volume. So the methane is distributing in that alveolar volume. So let's say that in your case it might be 4 liters of alveolar volume in which it distributes. And what that tells me is that where that methane went when we breathed in, so too did the carbon monoxide. So if I take out one of your lungs, your DLCO is going to be 50%. But when I account for the smaller VA, right, then it's going to come back up to 100%. All right, so what we're doing, that's how we get that, quote, corrected DLCO. And it does have physiological implications, as we'll see momentarily. All right, so I think that's a very important concept to kind of wrap your head around is, how we do this test and why we do it the way we do. There's the methane, does not go across. Carbon monoxide does. This just tells us how big our lungs are with respect to where the gas distributed. Now, you could have a person with bad COPD and they have huge time constants, and during that 10-second breath hold, the distribution of gas was in a very small space, even though their lungs are huge. It just never got to that bolus. It just never got to that poorly aerated part of the lung. And that's important information to know, too. All right, and we'll see an example of that momentarily. I'm not going to belabor this long. I had patients waiting in clinic for one, and you're probably falling asleep for two. But anyway, here's a nice little graphic here. You've got a decreased DLCO overall. It can be decreased in the context of normal DL over VA. All right, so this denominator is smaller than it should be, or it can be decreased in the context of an elevated or normal VA. And they have different pathophysiological implications, as you can see here in these diagrams. And I'm just going to walk through a couple of three of the more important ones. So this is what I call putting it all together, and then we're done. So here's our healthy individual. This one's going to be quite boring, but this is more to tell you how I look at a PFT, and no one has to do it the way I do it. It's just the way I just get a certain pattern going that I think gives me the best way to look at it and the most information. I look at spirometry first. Always look at the ratio first. Is the ratio normal or abnormal? The ratio here is normal. There is no I'm dictating. There's no airflow limitation or no airflow obstruction. FVC and FEV1 are within the normal range. Okay? So my spirometry has already told me a lot about the airflow characteristics. It may have given us a hint about the volumes as well. It's suggesting, because this is a vital capacity, that the vital capacity is normal. Probably the whole lung volume is going to be normal. That by no way can you make statements about lung volumes looking at spirometry only. You got to go to the lung volumes. And you know what I like to do is I like to look at the RV, and many of the patients I see that have COPD or asthma, they're going to do some air trapping or hyperinflation, so that may be elevated. So I want to look at that to see if it's up, especially if I see some obstruction up here, and we'll see that in a minute. So I start with the RV. You know, I can look at the FRC, which is the RV plus the ERV, and it also is normal here. And then finally look at the total lung capacity, and that's normal. So, you know, I'm dictating lung volumes are normal here. Diffusing capacity, I want to look at the overall DLCO, and here this resident did 44.3 with an average of 31.2, so he has excellent gas transfer. This is 142% predicted in his case. Obviously, his alveolar volume, he's got normal lungs, great gas distribution. It distributed in 7.77 liters. He was a tall guy. Hopefully still is. So therefore, the DL over VA is again, is normal. Okay, so let's take a look at a couple of cases of COPD, and this is where I think this whole VA concept becomes important, and we'll get to that. So this is obstructive PFT COPD, and what I'm showing you here is destruction of lung volumes. Think of this as like central lobular emphysema, where you've destroyed a lot of alveoli. You've got these big sacs with some vessels around them. You've essentially decreased a lot of the gas transfer area because you've destroyed a lot of the alveoli. This is the picture here. This is this individual. So again, we go through our paradigm. I look at the ratio first. I say, 47. FEV1, FVC ratio is low, is decreased. All right. Then I look at my FEV1 and my FVC. My FEV1 is 54% of predicted. And since I know this guy's got COPD, if you use the current global initiative on obstructive lung disease criteria, or the GOLD criteria, this would be considered moderate bordering on severe. Moderate is 50 to 80% predicted. So he's almost there to severe airflow limitation. So he's airflow limited. It's going to be moderate bordering on severe. I'm dictating again. That's what spirometry shows me. I look at the lung volumes. My RV is greatly elevated, suggesting some air trapping or hyperinflation. Likewise, my FRC is up in large part because of the RV. And then my total lung capacity, if you look at the total lung capacity, it's 122% predicted. The little star means that it's above normal. So this person is overdistended. My total lung capacity is overdistended. This person is, you know, I put money on this, and I don't gamble, that this is not an asthmatic. This tells me about elastic recoil. This tells me the stuff I've been telling you, where you destroy lung tissue, you know, the tethering's gone, the lung boings out because the chest wall's coming out. So this person is overdistended. It's almost severely airflow limited, air trapping with overdistension. And then what is going on with their gas transfer? It's down about half of predicted. Okay? And when we look at the DL over the VA itself here is 4.29 liters, but in context with the DLCO, it doesn't really correct anything up. So we're getting fairly decent gas distribution throughout these lungs. I mean, they're huge lungs. You know, they're 8 liters, and you're distributing in about half of that. You know, still not normal, but still a fairly good distribution, so you're not correcting the DLCO. All right, that's this one here. Let's take a look at a different type of COPD patient. Same exercise. Look at the ratio first. It's 28, really, really terrible. Look at the FEV1. It's 30% predicted. That's going to put you in severe. Anything less than 30 is considered very severe by GOLD criteria. All right, so if there's severe to very severe airflow limitation or obstruction here. Look at the RV. It's huge. FRC likewise is huge. This person again is overdistended. You can see here with the TLC being 143% predicted. And then we come down to look at the diffusing. It went 73%. 73% predicted for the DLCO. And the point I want to make with this, even though the lung mechanics, if you will, the flow and volume portion of the lung physiology is extremely impaired, there really is no correlation with the DLCO. You can't predict the DLCO based on the lung mechanics. It's all over the place. It's really quite striking, and here it is, very striking here. Now, in this individual, when you did the VA maneuver, he was able to distribute gas in 4.18 liters. You see how large his total lung capacity was, so there's still a lot of air where it didn't distribute. And then when you, quote, correct the DLCO, it does, quote, yeah. So in this in this case, the DLCO does correct for alveolar volume, but it's very different from someone who's got very small lungs in very small space to distribute gas. What's happened here, this person is air trapping to beat the band. There's an area of lung that doesn't see much air movement at all. So during that 10-second breath hold, in relative terms, that methane went into a very small space relative to the entire space of the lung. So in this case, even though the DLCO looked pretty decent, it's still corrected for alveolar volume. So this is telling me that where the gas goes in this guy's lungs, it's doing a pretty good job of transferring. I mean, this guy's lucky in that regard. Probably won't need HOMO2 until the DLCO goes below 50%. That's roughly about where we start needing home oxygen, at about 73%. Okay? All right. So let's take a look at the restrictive PFT. This is Our Lady with sarcoidosis. We look at the ratio first. 86, predicted as 83. This is normal. There is no airflow limitation or obstruction here. FVC and FEV1 are moderately reduced. Okay? So that's what I'm getting out of my spirogram. That's what I'm reading with that. And I move on to my lung volumes. RV, residual volume is decreased to 58%. FRC is decreased at 58%. Okay? Total lung capacity, again, decreased. So when all of my volumes are decreased to a similar degree, that's pretty much a restrictive impairment, be it neuromuscular or parenchymal. Okay, it affects all of the lung volumes in a restrictive pathology. Now, obviously, if you take the RV, 58 over 58 is 100. So, I mean, that corrected up, but that really is meaningless here in this case. So this person has no airflow limitation with moderate to severe restrictive impairment. It's a restrictive impairment. I like to use the word impairment because PFTs don't give you a diagnosis. It's not disease. They don't tell you about disease. They tell you about physiology. So I use the word impairment in my dictations. And then we look at the gas transfer part, and the DLCO is 14.4, which is only 48% of predicted overall. But when you take into account her small, tiny lungs, here's the VA down here, 3.06. And so it's a small denominator. It, quote, corrects up the DLCO. So what we tend to see in interstitial lung diseases, for the most part, is when you destroy lung, you're destroying both ventilation and perfusion units. You're destroying them equally. All right? So in most cases, you're going to see a crappy DLCO, but it's going to correct up for alveolar volume in most cases of interstitial lung disease. When it does not correct up, and I don't have an example here, okay, this is telling us that there's some kind of mismatching or inequality. And in human pathophysiology, it's typically a vasculitis or chronic thromboembolic disease, something affecting the perfusion part of the lung. The capillaries, the capillaritis, it could be something higher up in capillaries. Something that changes your VQ matching is going to not correct up a restrictive impairment. All right? And that's the end. I'm happy to take any questions. Yeah.
On clinic patients with standard COPD, do you recommend getting DLCO, or would spirometry 1.1 be sufficient?
No, I recommend getting the DLCO, at least on the initial workup, because it does tell you about how gases are transferring. If they're very hyperinflated, does it correct up? Is that more consistent with hyperinflation? And again, as I said, if their DLCO is less than 50% predicted, I'm going to check them out to see if they need supplemental oxygen, either ambulatory or continuous oxygen. So it does help dictate the steps I will be taking afterwards. So the DL is always good to have a baseline DLCO. Yeah. Right. 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 So sure. So in adults, the FEF 75 to 25 to 75, it does look at mid flows. The problem with that is that it's very sensitive to the initial conditions. I mean, because remember, you've got your spirogram and you're going to 25% volume and 75 and you're drawing a line through that. So if you just change your technique just the tiniest bit, the slope of that line changes dramatically. So the intra-test variability is up to 47% with the FEF 25 to 75. Okay? But having said that, it is useful to look at trends, and especially in our transplant population, those mid to late flows can be helpful, and they can predict roughly obliterative bronchiolitis, for example. So in selected situations in adult medicine, those mid flows are important. Sometimes, if the patient's really symptomatic, the ratio's normal, the FEV1, FVC really don't strike you as much, the FEF 25-75 is significantly down, you can say there's a suggestion of small airways. So sometimes when you're in that hedge or that gray zone, I use that to say there may be some very distal airways disease or something like that. Yeah, but that's a great question. Thanks.